permission to conduct the study. So our future goal is an integrated, comprehensive cancer control services in every district, which can be replicated across the state, and thus we can conquer all these common preventable cancers, which is still a far way and a distant dream for us. This is some of the activities we carry out on a regular basis, daily in the field. Thank you for your patience. Thanks.
For those of you who know Dr. Jaishree Gajaraj, a senior consultant gynecologist at Apollo Cancer Hospital, you will also know that there's never a time you'll see her without that serene smile on her face. During her period in the United Kingdom as a consultant in obstetrics and gynecology, she specialized in pelvic endoscopy and gynec oncology. Ma'am was also instrumental in introducing the HPV vaccination and cancer screening programs for the same. She will now give us an overview of her rich experience over the past 30 years in this field.
Good afternoon, everyone. It is indeed a great privilege to have been asked to talk on the experience of Apollo Cancer Hospitals. I'd like to thank our chairman, Mrs. Preeta Reddy, and the rest of the team at Apollo Cancer Hospital for giving me this privilege. If you look at this slide, you can see a whole number of women there, probably looking at something very interesting. Probably a film actress has come somewhere and they're all looking at that person. Or is it some kind of a mass selfie that is being taken? But as I look at these women, I wonder how many of these are actually going to develop a cervical cancer. And I hope that is what is running in each and every one of your minds too. We always say that we don't have detailed statistics, always crying about inadequate data, data which we have from smaller studies. We don't have a collaborative, big national statistic database. But I don't think we should be saying this. We should gradually be moving away from this. And I think this is where this major partnership will play a major role. This morning, we had a wonderful keynote address by Dr. Shanta, who gave us so many statistical figures, very, very impressive, what has been done over the last few years. And one of them that actually impressed me was the gender bias that is changing now. Cancers among women seem to be a little more than men. I think healthcare policymakers are wondering about the male to female ratio as such, but we as cancer care providers start thinking about why is cancer more among women. Breast and cervix, as we all know, are the two common cancers. And I will not be elaborating too much on the breast because Dr. Selvi Radhakrishnan will be talking to us about this. So let us as clinicians stop this constant cry. Let's stop this constant cry and try to see, even if we have 10 patients and we have some positive finding, let us make an attempt to present this somewhere. It will make an impact on overall care. Many of you may have seen this slide time and again, and I've just put this here not to show the statistics because it is not a very recent statistic, but just to show that India is colored red. And we need to probably start looking at different colors for our country. When we talk of so many million cases, we as clinicians, again, like to know, among that big group, per 100, how many are going to develop? Per 100,000, how many are going to develop cancers? So if you look at this, globally, 300,000 women die of cervical cancer every year, and a large proportion of them still present with inoperable disease. So where are we failing? Again, look at this burden of cervical cancer. You can see this huge, the Chennai followed by Delhi. You can see where we stand. Probably there is a little bias in this because the statistics come forth more from the metropolitan cities. But then we need to keep in mind that this is the trend that is happening, and we need to see if we can reduce the graphs that are going forward. Again, roughly about 132,000 diagnosed every year, 74,118 deaths per year. And even as each of us give this 20-minute talk, if you can calculate, every 7 minutes somebody is dying of cancer, cervix, in India alone, which I think was really, really a very startling fact. So again, instead of saying we don't have large numbers, we really don't, we just practice, we are private practitioners, we cannot document, it's wrong. I think we need to start documenting what we see. There are huge population-based registries, and Dr. Mallika again and Dr. Shanta this morning was referring to these. Our numbers need to be definitely reported so that we find a place on these registries. For example, now, Apollo Cancer Hospital, Tenampet, Chennai, cannot boast and say we have a registry and everybody report to us. We have pioneers before us who have done the work. So we have to take that effort to report each and every case. And these are wonderful, this Tamil Nadu and Madras Metropolitan Tumor Registries, along with the ICMR, are doing a great job, and we need to be very much part of this, although we all may have very small numbers. So we're talking of cervical cancer. We know the primary prevention is vaccination nowadays. Cannot ever replace secondary prevention, that is the cervical cancer screening or the cytological screening. Here, I would like to take you back to how it started. British Columbia, 1949, that was a long time ago, even before some of us were born. 85% of the population was screened, and they found, well into the 1975-85, when they took their statistics, there was a decrease in invasive cancer by 78%, and decrease in mortality by 75%. The same was also duplicated in the Nordic countries. These are all countries which actually maintain beautiful statistics. The UK experience has been something that we need to definitely share, and I'd like to point out that this is where probably we need to concentrate as well. Started in 1964, major disappointment because there was no significant decrease in the numbers that they were looking at. It took them some time to realize why. And the Lancet even said this was actually a death by incompetence. Indeed, a shame for many healthcare providers and clinicians. Pitfall here was the fact that they did one screening and they did not recall these women. And I think that's exactly what is happening in our country also. We are doing one smear, we are projecting statistics, but are we ever bringing these women back at regular intervals to follow them up? I don't think so, if at all, in very small numbers. Can this be implemented in our country? Definitely, I'm sure, with the resources available, and you've just heard Dr. Mallika talk about the beautiful screening camps that they are conducting. We need to somewhere, with all the information technology available to us in South India, we can boast of the best in the IT field. We can definitely start a program of recall. Almost everybody in the country now has a mobile, and sending a WhatsApp message or even a simple text message will be more than sufficient to bring them back for a recall. And I think we need to start concentrating on that. So for a successful screening program, we have to target the right population, which is very, very important. Either we tend to go into the districts and look only at the rural population, only at the lower socioeconomic group, and completely ignore the upper socioeconomic strata. So most of our information actually comes from that. As I said earlier, call and recall has to be somehow programmed into our screening programs. It has to be simple, effective technique. And if VIA-Willi has shown that it can definitely detect numbers, Tamil Nadu, I think, can boast that we are one of the first and the best to do this. We need trained personnel, sampling. Here again, a request to all the gynecologists who are here in the audience, we need to do a proper sampling, which means we need to use the proper spatula, use the correct transport medium. We need to fix immediately. So the technique of pap smear is very, very important from our point of view. And always to be read by a cytopathologist, not a pathologist. This again, we need to emphasize repeatedly. And we in our hospital have wonderful cytopathologists who can actually give us very good pickup rates. So the HPV vaccines, we're all aware of this, but the immediate one talks about the vaccine. The next sentence that follows is, the cost is prohibitive. We cannot apply it to the population. Only the really rich and the upper social class can actually take these vaccines. And then we sit back. So is that the right thing to do? We, I think, need to push our government. We need to impress upon them the fact that it will make a major impact on the incidence, not now, but in the years to come. And somehow try and subsidize it at least, if not provide it free. Which one you will choose, I think the debate goes on. So this is the WHO position paper, which was came out in 2009 when there was a lot of controversy on whether the HPV vaccination is useful at all and what is the efficacy. And here it says the WHO recognizes the importance of cervical cancer and other HPV-related diseases as a global public health problem and recommends that routine HPV vaccination should be included in the national immunization program. Now, in our country, the Indian Association of Pediatricians have introduced it in their immunization schedule. And FOGC, which is the Federation of Obstetric and Gynecological Societies of India, has also given a recommendation on wherever it is financially possible, we need to recommend HPV vaccination. So we move to our very own Apollo Cancer Care. I'm happy to say that we are one of the pioneers in the private sector. Across India, when this was started, it was the vision of our chairman to provide diagnostic and treatment modalities to as many people as possible. We have the state-of-the-art technology, and we have many centers which are providing cancer care across the country: Chennai, Bengaluru, Hyderabad, Kolkata, Delhi, Bhubaneswar, Madurai, and Nellore, which has been added recently. I still remember the day when Apollo Specialty Hospital or Apollo Cancer Hospital was inaugurated, and the speech that was given by our chairman at that time. And you could see the vision then, and I'm so happy to say that from that time, I have been part of this program, and I have seen us come a long way in this. So more than 25 years of cancer care here. We have an excellent multidisciplinary team. We have a wonderful rapport between the medical oncologists, the radiation oncologists, the surgical oncologists, and I'd like to say, in brackets, the gynae oncologists as well. Absolutely no doubt about the diagnostic and treatment modalities that are available. It is a major referral center from across Tamil Nadu and across the country and overseas as well. And we run a very, very efficient preventive healthcare program as well. Our referrals, again, as I said, from across the world and across India. Important to say that we have a dedicated paramedical staff. It's not enough if you have the latest in radiation technology, if you have the latest medicines available. The paramedical staff, now for example, chemotherapy, the people who actually administer it, their attitude, their compassion for the patient, this is something you can see at Apollo Cancer Hospitals. And even when they come for the radiation, maybe 4 weeks, maybe 5 weeks, each and every patient, individual recognition, and the care given to them by the paramedical staff has to be acknowledged. We have, again, a very, very good cancer support group started by Neerja, which is here with us today, along with a group of cancer survivors. And I think they have been doing a great job. We very often have difficulty sometimes convincing our patients to take care or to go for treatment at all, because for several factors, either they don't want to, they don't want their sons or sons-in-law to spend money. They feel, I'm already 60 plus, why should I live? It's okay, I have a cancer. But the cancer support group has motivated these people and brought them forward for treatment and seen them through not only completion of treatment, but even post-treatment. As I said earlier, advances in diagnostic technology, I don't think the facilities available at Apollo Cancer Healthcare cannot be paralleled anywhere. Similarly, in the treatment modality as well. So we're talking of somebody who comes with established diagnosed cancer. Yes, we have everything that we can offer to offer. Are we neglecting a group of people in this? Are we neglecting the group who don't yet have cancer, but who may develop cancer in the years to come? So our data, an average of about 12,000 patients treated annually, and the gender bias showing here again, of which 70% are women. The common cancers in order of occurrence at our hospital are breast, cervix, ovary, stomach, head and neck in women. So this is the data as we could trace it from 2008 to 2015. And you can see that I've highlighted breast as 670, ovary as 241. But surprisingly, cervical cancer at our center is only 84. I was wondering what the reason for this could be. Breast awareness, treatment for breast cancer. definitely everything is available. But cervical cancer, as we said, still presents at stage 3 and stage 4, where many feel that treatment is not possible, and probably palliative care, this is not the place we should be going to. So we do not have too many cervical cancer cases coming to us. Breast and ovary are one of the highest. I thought I would draw a parallel to the Institute of Obstetrics and Gynecology at Egmore, a premier institution in the state and the country, with a large turnover of patients. And here, if you can see, let us focus again on 2015. Total number of new cases, 300. And here we have cervical cancer as 159. Breast will not feature here because at the institute, breast cases are not treated. They probably would go to the government general hospital or the surgical oncology unit. So here we know cervical cancers are high. You can trace it way back from 2010 and see the numbers. So if we go back, we can compare our statistics with the institute. And here we're talking of two different populations. One, the so-called upper middle class and the upper class of patients. And at the institute, the lower or the less deprived socially economic group. So when we look at all this, we need to probably change our focus a little bit and say, preventive health checks are probably the way forward. We started initially with what was called the well-woman checkup, the master health checkup, and then we moved on to call it the preventive health check, which I thought was a better terminology. We introduced the gynec cancer screening check about 15 years ago, and for some reason, the popularity for this was very, very low. The number of takers, they would rather go for the regular preventive health check than go for this. But more recently, we have introduced the organ-specific cancer screening program. And I personally find that there's a large number of people now coming forward for this because they're able to identify with a particular organ. And as Dr. Rajiv was talking to us, this family history of cancer seems to be really overtaking everyone. So if a patient's relative is admitted for a CA breast treatment or surgery, they immediately feel that they will be a victim very soon and they want to come. And here when they see an organ-specific screening program, they opt for this much better than the regular gynec screening checks. The mammogram data we were able to get, we can see on an average, this is quite a good number for a setup like ours. The number of people coming forward, and many of these also are referred from the preventive health check sector. The cervical smears, predominantly from the preventive health checks, is what we get. We were initially doing the conventional smears only, and about 5 years ago, we switched over to the liquid-based cytology entirely. We no longer do the conventional cytology. And as I've said earlier, we have an excellent cytopathology unit. It's important here to emphasize that wherever you do your smears, apart from the technique, the smear has to be read by somebody trained in cytopathology, somebody trained in looking at cervical cells. It's extremely important. And we get a lot of patients, especially from the Northeast, with positive abnormal smears. Ascus is a very, very commonly reported pap smear result. And when we actually come here and either do a colposcopy for them, because the current recommendation is a colposcopy when there is even an ascus, we find that the colposcopy is absolutely normal. Or if the time interval between the last smear and now is at least 6 weeks, when we repeat a smear, we find that it's absolutely normal. And reviewing some of the slides that were taken in the earlier centers, we have found that reporting HPV infection or coilocytosis as CIN2 seems to be very, very common. And so when they are not able to place it in any category, they immediately put it as ascus. So on average, about 1,000 smears are done annually. So these are the profile of women taking the check. Some are pre-employment, so they are in their early 20s. You have mothers of patients or mothers of people working in industries where insurance cover is provided for this, or their wives, and relatives especially of patients who are admitted. Now this is a group who have financial access to healthcare. So they come to us, they're predominantly urban, they have access to media, they have access to the internet, they are supposedly the knowledgeable or the knowledge group. But when they come in for this preventive health check, they've had their bloods, they've had their ultrasound, they come into the gynecologist's room, absolutely no clue on what is going to be done for them. And when we tell them that a pap smear is going to be done, many, even after actually lying on the couch, refuse to have the pap smear. Because one, they don't want to have an internal examination. They feel, what is cervical cancer? I will not get it. My son wanted me to come for the health check, so I have come. And here is when sometimes we counsel with a lot of patience, sometimes we counsel